Yes.
Okay, so hi. I will do a little introduction in Hebrew, and then I'll pass to Hans and Ruth. Okay? So, אני רונן, שפי, אני מחברת בפקס. היום אנחנו עושים עם חברת אנרף, אנחנו עושים וובינר בתחום של גלים קצרים, כמו ששלחנו. בכל מקרה, בקרוב יצא כבר מכרז, ומי שזה נראה לו מעניין ואפקטיבי, וחושב שזה יכול להיות יתרון, אז מוזמן להתחיל לפעול בכיוון דרך החברה, דרך מכבי. זהו, ואני איש הקשר של מכבי, בכל מה שקשור לתחום של פיזיותרפיה, שיקום, ריפוי בעיסוק, אז מוזמנים, אז נעים מאוד, ואני מעביר את השרביט להנס ורוס.
Okay.
היי.
Yes. Bye, kun jij omschakelen naar mij? Ja. Okay. Good afternoon, ladies and gentlemen. My name is Hans Sein. This is Ruud. Ruud Luijks.
Welcome.
Both of us are physiotherapists at this moment working for NRAF Nonius. Ruud is an international product manager and a physiotherapist, and I'm an international sales manager, also physiotherapist. Our scope of work is always getting in contact with people like you, so that we are interacting through the internet, doing these kind of webinars or visits to Israel, to other parts of the world. And yeah, we are excited to get in contact with you. We saw that your group is a huge healthcare facility in not only in Tel Aviv, but all over Israel. So that is really nice to meet you. Before we start the introduction, I would like you to hold your questions until we finish the webinar, because then we have a little bit more attention to the questions and answers. And further to that, obviously, if there is anything after this webinar and you missed to ask or whatever, then you can always get in contact by email, via BPEX, or directly to our email addresses at NRAF Nonius. And then, yeah, I think we should start. So the summary for today, obviously, we will take a closer look and an intense look to shortwave diathermy. We will do the introduction. We will go to classification of heating agents, an ultrasound and shortwave comparison, whereas we also will step aside a little bit to other EPAs. Then we will take a look at the advantages of shortwave, the transfer of shortwave energy, the biophysical effects, of course, of shortwave diathermy, whereas we try to translate biophysical effects to treatable possibilities. And in that, we also take a closer look to the thermal effect and the non-thermal effect, because there is a recent scientific activity where we see that every now and then non-thermal effects are even surpassing the possibilities with the thermal effects. But like I said, that will be done by Ruud. For now, I will start the first part of the webinar. Yeah, the introduction. What is shortwave diathermy? If we would to set a definition to that, then I could say that shortwave diathermy uses oscillating high frequency, non-ionizing electromagnetic energy, which is similar to broadcast radio waves, in order to produce deep heat within the tissues. But that is the definition. So then, if we speak about shortwave diathermy, what is diathermy itself? It's an application of high frequency electrical currents. They cannot depolarize motor or sensory nerves, as the wavelength is still too short to facilitate these motoric reactions or sensory reactions. However, due to the high frequency, they will pass through the tissues quite easily, whereas they can cause a molecular vibration or friction, or how you want to call it. And this particular vibration and friction can be a little bit seen as rubbing your hands. You create a friction what's the result? It's that you get a better perfusion, a better blood flow, and also you create heat. And that's exactly what we also see here. But we can also see that shortwave diathermy in a non-thermal way has a lot of beneficial effects for physiotherapy, for motion and muscle and bone. So we will go in detail towards that possibilities. Now, we discussed diathermy, then what's left is what is shortwave. Like I already said, that's a little bit comparable to a radio transmitter. Within the scope of our medical expertise, we see three main frequencies, the 20.12 megahertz, the 30.56 megahertz, and the 40.68 megahertz. However, we are basically mainly using this frequency at a 27.12 megahertz, which gives a wavelength of 11 meters, and that is the most common used. So imagine that you are using an electrical physical agent that is using 27.12 million pulses per second. So you can imagine when that goes into the tissues that you can enhance quite a bit of molecular or tissue-like tissues. So you can see here from radio waves to microwaves to ultraviolet, etc., etc. But keep in mind that we are basically using this one. Now, when we look at the background information on the physics, then you see that electromagnetic fields contain energy. And this energy is responsible for electrical currents in the body. And electrical currents is responsible for heat production, specifically in wet tissues with good blood supply, like muscles, but also the blood vessels themselves. Also, the fatty tissues, as they also contain quite a bit of fluids. The concentration or the strength and location of the energy depends on the field line density. For instance, in the capacitive method, whereas you can use two electrodes, whereas you can make one smaller, or you can take the difference from where you go into the tissues. But this is particularly something that Ruth will focus on, so I'm just keeping it mentioned, and then Ruth will go in detail there. And also the amount of electric field to magnetic field depends on characteristics of the machine itself, depending on the manufacturer or the type of electrodes that we use. For instance, in inductive, where you're using the magnetic energy instead of the electrical energy. Okay, this was the first introduction. Now let's go a little bit back to basics and see what is the classification of heating agents? What are the more used EPAs in our scope of physiotherapy? Then we see on a superficial level, we can work with infrared lamps, IR, moist heat packs, paraffin baths, and warm whirlpool and/or immersion. Of course, you can put your extremities into, for instance, a paraffin bath or in warm water. When it comes to deep heat, then we know the microwave diathermy, shortwave diathermy, ultrasound, and of course also TECAR, which is more the long wave on a 500 megahertz frequency. Now we will do a little bit of an ultrasound and shortwave diathermy comparison. And this is not so much just to go to the side of ultrasound, it's more for you to give a thought about, hey, when will I use which EPA on what moment? And we will go in detail because we find, or we more or less follow the strategies of Professor Tim Watson from England. And in that sense, you can immediately see, hey, what is shortwave doing in terms of retention of heat or penetration, etc. But you can also see when do you make the change or when do you choose for ultrasound or for shortwave, and also for other modalities. Now, if you take a look here, then, for instance, if we compare ultrasound to shortwave diathermy, then we see already that the energy type is already strongly differing, as ultrasound is, of course, more of an acoustical, mechanical vibration, whereas shortwave diathermy is more of an electromagnetic modality. The tissues that we are heating within these modality in terms of ultrasound is collagen rich, or the connective tissues, like ligaments, tendons, fascia, capsules, and scars. Whereas the tissue with that is stimulated with shortwave diathermy is more with a high water content, like skin, like adipose tissues, like muscles and blood vessels, etc. Now you can see that the penetration is a little bit more with ultrasound and then specifically with the 1 megahertz. However, the penetration with the shortwave diathermy is 5 centimeters, but that is already after you passed skin and fat already. So it doesn't differ much in terms of penetration. And of course, if you look at the tissue volume, then with the ultrasound treatment head, the biggest one we have has a geometrical surface of 5 square centimeters. And then with the absorption and with the scattering, etc., we are maybe able to reach a 20 centimeter area. Whereas, of course, with the shortwave diathermy, we work with much larger electrodes. The temperature increase, because if we talk about heat, then we see that with the 1 megahertz, we see in temperature increase of 3.5 Celsius. And with the 3 megahertz, a lot more. It's 7.5 degrees centigrade. How do you say that? Centigrade, huh? Yeah, okay. So you must imagine that this is also differing quite a bit, but that has also to do because with the 1 megahertz, you have a much more deeper penetration than with the 3 megahertz, which basically has a relative superficial penetration. If we now look at the shortwave diathermy, then we see that with the with the capacitive method, we have a 3.9 centigrade or Celsius increase of temperature. But with the inductive method, we see a 9.4 degrees of centigrade improvement of the temperature. So you can see that with shortwave, you have quite a not only a deep penetration, but also quite an increase of temperature when you are applying these kind of machines. And when you then look at the heat retention, which is with ultrasound only 3 minutes, then you can see with shortwave diathermy, it's even more than 9 minutes. So for some reason, the energy of shortwave is really holded in the tissues. Now we will step aside a little bit because as I was already showing you the combination between ultrasound and pulsed shortwave, then this is also quite nice because it gives you the possibility, if you look at the charts, that you can immediately see why you should choose for whatever EPA. For instance, if we look at the ultrasound treatments, then you see dense collagen-based tissues are well absorbed. And then we speak about ligaments, tendons, fascia, joint capsulas, scar tissues, etc. Whereas the pulse shortwave, already spoken, the wet ionic low impedance tissues like muscle, nerve, areas of edema, hematoma, or effusion. Effusion is the transport of gas. And within the scope of laser, we see a superficial vascular tissues like open wounds, like muscles, like nerve, and like tendon. And then basically the next slide is even a little bit more important because you will see the penetration of those electrophysical agents. We see that laser at the 600 nanometer wavelength has a very small penetration, just a little bit over 1 centimeter. With the 905, we see that we roughly have 35 millimeters. With radial shockwave therapy, we see maybe 4 centimeters. With ultrasound, we see 6 centimeters, maybe 7. We never know exactly what the absorption rate is for what kind of tissue, so it's always very difficult to calculate on that. But we see specifically with focused shortwave therapy and pulsed shortwave therapy, large and deep penetrations. We spoke just 5 centimeters past the skin and fat. Apparently, Professor Tim Watson is even mentioning 10 centimeters. It's just how you look at it and what you are reading for content in terms of scientific reviews. So why did we do this? Just to to show you that there is a very structural way in when to choose for what EPA. So let's continue with the shortwave. What are the advantages of shortwave, or what's in it for you, or what's in it for your patient? We see a deep penetration. We also have a hands-free therapy, which means that basically you can work on something else, or you can even get the patient a cup of coffee or whatever you think that you can do at that time. It covers larger areas, and as we already spoke, when you speak about rehabilitation of muscle groups, of muscle injuries, then specifically on the lower extremities, you will find, and even in the low back area, you will find larger groups where shortwave therapy would be a good choice. A deeper tissue heating without heating the superficial tissue. This is a huge advantage, specifically when you're working with the inductive part, because heating up the skin is not particularly a therapeutical action. It's more, what kind of regeneration of tissue do we find on the deeper layers, because that is mostly where the injury is. The awareness, however, with the patients, when you are heating up the skin, is already a very therapeutical experience. But I think with specifically the inductive method, it's better to really go at the injury instead of only heating up the skin, whereas the brain gets a signal in the hypothalamus that we are feeling nice and warm. We would like to have a therapeutical level in this kind of treatment. But also that is something that you will stipulate on pretty deep. Then also when we look at the pulsed shortwave, then there is quite a recent scientific attention. This also will be discussed by Ruth, because we can also show you some quite valid or clinical relevant studies that have been done recently on these kind of modalities. Further to that, specifically within the inductive way, we can say that there is a very solid safety. There is no stray radiation anymore, or at least no stray radiation that is endangering your patient or your therapist, for instance, in pregnant women. And it's a very user-friendly machine. But I think you already had the demo from Bapex. Otherwise, we can still show you in a couple of minutes how the machine is working and how practical and pragmatic it functions. So the transfer of shortwave energy, that is your cup of tea then?
Yeah, it is.
So Ruth will take over from here.
Good. Okay, Hans, thank you very much. So now that diathermy has been introduced and shortwave diathermy is positioned as an heating agent, we can now look on how this energy is entering the body in order, of course, to achieve certain therapeutic benefits. In other words, transfer of energy. Now, actually, Hans already mentioned that the concentration of energy depends on field line density, as well as the amount of energy and type of electrodes. In shortwave diathermy, there are actually two methods, and the methods are named after the type of electrodes that are being used. There are the capacitive field method and the induction field method. Both will be explained. Before I do that, it's good to know that shortwave diathermy devices, machines, are capable of producing a lot of output energy, even up to 1000 watt. But keep in mind that the output intensity does not reflect the amount of energy that is actually absorbed in tissue. Unlike, for instance, superficial agent like a hot pack, the energy in shortwave diathermy is capable of penetrating through all tissue layers. So not only superficial, but also deeper layers. Which type of tissue that is actually affected, that depends very much on, first, the positioning of the tissue related to the applicator or the source of energy. Secondly, the composition of the tissue itself. if it's muscle or fat tissue or bone. And last but not least, also the type of method that you apply, inductive or capacitive. Let's first have a look at the capacitive field method. Now, capacitive field diathermy is actually a method that you can see here where you have two electrodes. For instance, this could be an example of a transverse application where in between the electrodes is a knee joint, for instance. So the tissue is in between two insulated because it's covered with a sort of, plastic cover. And the joint is positioned in between the electrodes. Then what you see here are the field lines. So the energy is flowing from one electrode to the other. And Hans mentioned that electromagnetic energy is causing friction. And that's what you will see here. The ions start to move from one electrode to the opposite electrode, but in a very fast rhythm, 27.12 million times per second. That's creating friction inside the tissue, and as a result, there will be heat. Now, talking about heat, in what tissue is the heat most accumulated? Well, in the case of the capacitive field method, you will see here, if we go from the surface
Okay.
Yeah, we are back on track. Right. Okay. The last thing I was mentioning is that the electric field is much stronger than the magnetic field. And the electric field, which will cause some heat accumulation in superficial layers, could also involve the risk that you overheat areas with a large fat content. So that's something to keep in mind, that superficial layers can easily be overheated. Now, you also see from this scheme that heating occurs in subcutaneous tissue and superficial muscle layer. Now, this was the first method developed for shortwave diathermy. But in physiotherapy, you could ask yourself the question, how important is it to be able to heat up superficial tissue? I think in most of the problems that we face, we are looking at structures that are more deeply located, muscle, tendon, etc. So later on, there was another method developed, which is called the inductive methods. And we will have a look on what is the inductive method and how does it work. First, I will show you a little bit from a technical point of view how such an electrode is constructed. What you see here on the right-hand side is a sort of electrode without any shielding, but this copper winding is a sort of coil. And in this coil, there is this electric field rotating with that high speed of 27.12 million times per second. Now, there is another phenomenon, which electrical current, that is what is called the Maxwell rule. An electric field will generate a magnetic field, and a magnetic field will create an electric field. So if you imagine that here we have an electric field, there's also a magnetic field. And in this rule, a magnetic field is always coming out perpendicular to the direction of the electric field. In other words, is crossing out in this way. Now, the magnetic field itself will also have an effect in tissue that is called eddy currents. I will explain later with a slide on how it's actually working and what will happen in the tissue. But keep in mind that this eddy current will also cause friction and produce heat, but more on a deep level. So in general, inductive field diathermy means that you are basically using the magnetic field, but the magnetic field serves as a carrier for the electric field and allow it to penetrate deep into the tissue. To go and have a look at on where heat is accumulated compared to the previous slides with the capacitive method, you will see here again that the patient is positioned in front of the radiator. It's called a circuplode or an inductive electrode. And in contrast to the capacitive method that you will see here, the capacitive method uses two electrodes. Inductive is only one radiated that you see here on the left side. Now, imagine that in this circuplode or electrode, we have here the coil where there's the electric field. The magnetic field is coming out perpendicular, so in this direction, into the knee joint, for instance, creating in the tissue those eddy currents. And actually, the eddy current, electric gives magnetic, magnetic gives electric field. So actually, the field that you will see here is a mirror of the one that is produced within the electrode. Now, the electrode itself is something special because there's a sort of ferritic screen in front of the electrode that prevents to a certain extent the electric field to come out, because you want the magnetic field to be able to penetrate into the tissue. If you look at the distribution of the heat, the result will be that there is less heat production superficial, and most of the heat will be generated in deeper structures like muscle, as Hans already mentioned, up to 5 centimeters beneath the skin. There's something else that is important to realize. Both capacitive and the inductive can produce heat. But keep in mind that the thermosensors, the one that can pick up any heat, are found in the superficial layers. So with the capacitive methods, you easily will generate heat. It's superficial. Those sensors are triggered easily, so patients will report quite soon after you start the treatment that they have some sort of heat sensation. In case of the inductive methods, it will take longer before they can report and give you some feedback on if they feel heat and to what extent they will feel heat. That's because in the superficial layers, there are hardly any thermosensors. And the only way for people to give some feedback on what they feel is by means of conduction. The deeper layer is heated up, and via conduction, that heat is transferred to the superficial layer where the sensors are triggered and they are able to give you some feedback on it. So this principle of inductive field diathermy, that is called dissipation. Now, actually, it is the way of an inductive method to heat up this deep tissue. Conduction is the way where this heat is transferred to the superficial area, and patients will be able to report what they feel. So, summarizing before we continue to the next part, is that shortwave diathermy application involves placing a patient or a joint, of course, in the unit's electromagnetic field. That's for the inductive methods, or directly in the electrical pathway, and that's for the capacitive method. And in the body tissues, the energy is converted to heat. Okay, so keep in mind two methods, capacitive and inductive. So the next part, there we will have a brief look on what's happening in the tissue. We have seen the way how energy is transferred. Now we are going to look on what's actually happening inside tissue. The first part, what you will see here, the biophysical effects, will be a sort of summary on effects in general. And in the sections that will follow, both Hans and I myself will explain more into detail the biological effects. So let's start with this one. Now, by now it will be clear that effects of shortwave diathermy are both thermal and non-thermal, hot or cold to a certain extent. A simple comparison. Now, shortwave energy will be converted to therapeutic effects in tissue. And we will first have a look at thermal, non-thermal, but once again, we will do that very briefly because afterwards it will be more extensive explanation. First, we have to understand what is thermal, because in thermal shortwave diathermy, the effect is actually an effect that results from an increase of the blood temperature. It's a stimulation of thermal sensors in the skin or by local thermal tissue damage. Well, the results will be basically results that are involving peripheral nerve system as well as the central nerve system. I want to say at this stage that diathermy parameters are not precisely controlled. So it means that the amount of heating cannot be accurately measured. And it's something you will see also in the devices and the output of the devices, that you need a lot of energy, but the amount of energy that's actually doing the trick, in other words, giving therapeutic effects, is not actually known. Fortunately, we have the Curapulse, which is a device that is probably one of the few that is allowed to indicate on a screen what energy in terms of what is actually transferred to the tissue and what actually is absorbed and reflected. We will come to that later. So keep in mind, thermal, it's a general effect, increase of blood temperature and stimulation of thermosensors. Now, the non-thermal is more on a cellular level. It's very localized. It's an influence on local metabolic process. And the central nervous system, your hypothalamus, is not involved, the thermostat of your body. As I already mentioned, both thermal, non-thermal will be explained more into detail in the next few sections. Whereas Hans will take over from me and we'll start with the thermal effect. And I will get back to you later with non-thermal effects.
Okay, right. Thank you. In terms of thermal effect, we will first take a look at the physiology and then also how to use it in therapy. So within the scope of thermal shortwave, we see an increase of tissue temperature, and this will inflict a general increase of metabolism, an increase of vasodilatation or an improvement of the blood flow. The supply of nutrients and oxygen is going up, and we see an accelerated removal of metabolic byproducts. So that is the first part that we will enhance when we are using shortwave on a thermal basis. On a therapeutic level, we see with the heat, with the thermal heat, an increase of tissue extensibility, the elasticity of ligaments, capsulas, and muscles, which means that they can function as a pre-treatment for mobilization techniques. We see a decrease in muscle spasm, muscular relaxation. So this is also something that already on a therapeutical level can be very beneficial, as you see a lot of people with muscular injuries and muscular spasms in your practice. Tissue healing will be increasing, and because of the transport of byproducts, most of the time you will see that when metabolism is stimulated, metabolic byproducts are transported, you will see a decrease of pain or analgesia. Let's go a little bit in detail of the effects of thermal shortwave diathermy. In general, increase of tissue temperature by 1 degree Celsius will increase the metabolism with 13%. The increase of tissue temperature by 2 to 3 degrees Celsius will have an effect for pain and muscle spasms. An increase of tissue temperature by 3 to 4 degrees Celsius will give a positive influence on tissue extensibility and, as I already spoke, pre-treatment for mobilization. So how does that work on a physiological scope? You can see a catalytic effect, catalytic effect on all chemical processes on a cellular level or on a tissue level. The application of heat results in an increase in the local metabolism of the cell and increased transport through the cell membranes. I'm sorry, guys, that I have to read this, but we spoke extensively about it's very difficult to make your own story for this difficult cell physiology. And it's also something we will send you the presentation, sorry, and the video, so that later on you can verify by yourself if this is all correct, okay? So I will continue. For every increase of 1 degree Celsius within the physiological limits, as if we put in too much heat, we will also enhance tissue damages. So it needs to be within the physiological limits. The metabolic activity increases by about 13%. This local metabolic increase leads to an increase in the oxygen partial pressure, the PO2, the carbon dioxide partial pressure, the PCO2, and the acidity, the pH. These three factors, the PO2, the PCO2, and the pH, determine the local perfusion by their effect on the capillary sphincters and the met arterioles. The pre-capillary sphincters and the met arterioles in the tissue relaxation. This is a sort of peristalsis effect, as you can also see in the other parts of the body. This alternating activity controls the perfusion of the capillary beds. At the same time, the contraction forces the blood in the capillaries forwards. This process of autoregulation is also referred to as vasomotion or vasomotion. The degree and duration of vasomotion is principally determined by the oxygen concentration. And then the last explanation of the physiological effects of thermal shortwave, the dilatation of the precapillary sphincters and or the met arterioles increases the perfusion of the capillary network and hence that of the tissues. At the same time, the blood flow velocity decreases, resulting in an increase in the exchange of substances by diffusion and filtration. This maintains the local and improves the local homeostasis. So that was a short part. So now I made sure that Ruud will do the rest.
Thank you.
You're welcome.
All right. So, I mentioned we will have a closer look on the non-thermal effects. No, before I start, Hans mentioned thermal effects. Dissipation will generate heat, and exposure to heat will increase the metabolism. But that does not necessarily lead to an elevation of tissue temperature, because as a result of vasodilatation and conduction, the temperature will not rise further as long as the surrounding tissue is colder or lower in temperature. If not, then the body will react to heat exposure by systematic reaction, thermal effect, which will be triggered by the blood temperature and the thermosensors. And such a systemic reaction will show itself because your body temperature will go up, your pulse rate will go up, your respiratory rate will be higher, and your blood pressure will be lower. These reactions, of course, have the goal, and it's a reaction of the body to try and diminish the heat production, which will be visually by vasodilatation, or visually, I mean by sweating. One of the ways to get rid of excessive heat. Now, I've mentioned that it's not always necessary to have a rise in tissue temperature. And in the non-thermal effects, it's actually on a local level without the involvement of the central nervous system, our thermostat. So, regarding those specific effects, the non-thermal effects, they are important because they involve cellular effects associated with a lot of disorders that we see in physio. But secondly, there's also recent and strong evidence for those specific effects. There are indications that are evidence-based, and those indications, or in general, searching in PubMed for pulse shortwave, because if we speak about non-thermal effects, we often speak about pulse shortwave, because shortwave could be given in a continuous way, non-stop, sending energy to tissue, or in a pulse way with a short interval time to allow the blood flow to get rid of some excessive heat. Now, in pulse shortwave, you can also control the number of pulses, the frequency, the duration of each pulse, and the average energy. And especially average energy has become more and more important in determining the dosage used to achieve certain effects. Now, a couple of years ago, in 2018, we have introduced our latest device, the Curapulse 670, for which this webinar is organized. And nowadays, when developing a new medical device, it's necessary for us as a company to come with a lot of proof for the therapy, in this case, shortwave diathermy. What we have to do as an obligation that comes from medical device regulations, we have to write clinical reports. That means that we also have to search in databases for good level of evidence, good level of literature related to that specific device or therapy. So when we, at that time, were searching PubMed, one of the databases, we came to 60 relevant scientific studies of a good level for pulse shortwave. Now, in many countries, physiotherapists would like or would appreciate to have at least a protocol for a particular type of disorder to facilitate the start for treating various conditions. So from these publications, we could extract almost 30 evidence-based protocols. Now, we have searched PubMed, and later on we will show you some sort of summary of literature that we have used. But in PubMed, or if you are going to search yourself, I would like to advise you to search with the keyword diathermia. What we did is diathermy is one of the mesh keywords, medical subject headings, as you probably know. And medical subject headings are standardized keywords that you could use when searching, for instance, PubMed. Now, the mesh terms, they have been assigned to almost 90% of all the articles that are stored in PubMed. And it's also to indicate the content of an article. Why searching via a mesh term? Well, the advantage is that all or any different description or synonym for, in this case, shortwave diathermy is automatically included in your search. I will give you an example. For instance, in oncology, if you would like to find articles on cancer, well, it can be described in literature in various ways. For instance, cancer with or without an S. Tumor can be described in various ways. Neoplasm, etc. There are various words or synonyms for actually the same field. Now, if you would only search for the word, for instance, cancer, and if you do not use a mesh term, you will find a number of articles, of course. But if you would use the mesh term, in this case, neoplasm, you will find articles on that subject, regardless of the word that you have used to describe this field. It also means that you do not miss out any article. So we also have been using diathermy to make sure that we could include all recent and relevant publications. Okay, what did we find? This is just a summary, and that was also coming out or published in a publication from GWO, 2011. And that was related to the non-thermal effects of pulse shortwave. So far, a lot of effects of shortwave diathermy were related to thermal effects, the heat. Now, strong recent evidence, what does it mean? From these evidence, we have seen that soft tissue for pain and edema in a post-operative setting, but also non-post-operative, for instance, after a sports injury, shortwave diathermy is beneficial. It's a non-invasive treatment. It can be applied locally to the target tissue, the muscle, tendon, ligaments, etc. It also has been proven that it can facilitate the recovery time, which means that if you would stay in hospital, you can reduce the length of stay. In other words, it will become cost efficient. More recent, it has been shown that it's actually quite effective in treating disorders like diabetic and with diabetic chronic wounds and wound healing. The effectiveness in promoting healing of difficult to heal wounds, like the diabetic or chronic wounds, makes it an important adjunctive wound healing treatment option, particularly for wounds non-responsive to the standard or care treatment. And with the number of patients presenting diabetes on the rise, it will increase, that's the expectation in the next decades, and as well as a growing geriatric population, this is something worth mentioning. So keep in mind, not only for soft tissue, but also wound healing, an indication where there's a lot of evidence out there. Besides, it has been demonstrated to have a good efficacy in a lot of other clinical areas with limited risk and easy to use. Limited of risk, I will come back in one of the next slides. But it's also anticipated that PRFE, that's one of the synonyms that you will find, pulsed radio frequency electrotherapy, will become more important in the years to come. So this is sort of a general summary on the non-thermal effects and the evidence that's out there. Now, why pulsed? I already mentioned the advantage of being able to control frequency and duration of the pulses, and as a result, the average dosage. First of all, it's the evidence that's out there on pulsed shortwave, especially the last decades. Pulse shortwave diathermy have become even more important than continuous shortwave. And with the pulse shortwave, it's also possible to more fine-tune your settings and your dosage compared to the continuous one. Now, it also has been shown that nowadays it's safer for the operator. Regarding safety, in the first few years after the introduction of shortwave devices, the operators of the equipment, the physiotherapists or the doctors, they show the same symptoms as those who were operating very powerful shortwave radio transmitters. And the complaints that they saw with this group of people were associated with anxiety, for instance, tiredness, depression, headache, insomnia. And although now the modern shortwave equipment produces fewer undesirable radiation effects, a certain amount of care is still appropriate, and it's also advised to stay within a certain limit of the device. And as a manufacturer, we always have to mention the precautions when working with shortwave devices. But compared to the continuous, the older model of shortwave devices, for instance, the Curapulse, being a pulse shortwave device, is one of the safer devices with very little stray radiation. It's also measurable, and it stays within, there are reports, less than half a meter, 50 centimeters surrounding the device. So if you are away 50 centimeters from the device or the cables, the field density is almost reduced to zero. So that's a big difference with the first devices that were introduced many years ago. So that's related to safety and pulse shortwave. Another reason why pulsed is, like I've mentioned before, the increasing number of publications. If you have subscribed, for instance, to Pedro, the newsletter, where you can indicate fields of expertise like chronic pain or musculoskeletal, you will also find publications recently added to the database. And as I've mentioned before, one way to check for you yourself if it's not something that we present is to just check by using those mesh terms. Hans already mentioned we follow closely what Tim Watson is mentioning and what he is writing on his website, Electrotherapy. We also have been looking at, for instance, Canadians, Bélanger. He has published a good book on evidence on not only shortwave, but also on other modalities like ultrasound, laser, electrotherapy. So all APAS, electrophysical agents that are interesting or that could be interesting for physiotherapy. So when it comes to the effects of non-thermal shortwave, I've mentioned that heat can be produced, but it can also be controlled. The amount of heat, although not measurable, can be controlled. And a certain heat production, dissipation, will improve the vasodilatation, which on its term will increase blood flow. Actually, those are the effects mentioned by Hans in those slides that he has summarized, like the capillary filtration, the pressure, the growth, the perfusion. And also it will be the increased fibroblast activities. Now, fibroblasts are the main cells of connective tissue, and they are responsible for the synthesis of all elements of the matrix, the collagen, which is actually the non-elastic part, but important because it provides a certain strength to that particular tissue. Tissue that's also relevant for a number of indications that we as a physiotherapist would like to treat or focus on, like a shoulder joint, ligaments, capsule. Now, talking about that, adding a certain amount of heat, so it's still non-thermal, it does not actually give an extensive sense of warmth, but it will help tissue to become more flexible, the elasticity. So it will alter the collagen property, and it will allow it to elongate, stretch a certain type of tissue. That effect, the elasticity, is, for instance, beneficial when, for instance, a frozen shoulder. Before I would go with my patient into a gym to increase range of motion, it could be an idea, for instance, to use pulse shortwave on the shoulder joint, just to add a little bit of heat, non-thermal, to allow the collagen to become more flexible and make your exercise therapy in the gym more effective, because the tissue, in this case, connective tissue, will loosen up, which allows the patient to more easily, or with less pain, to start working on improving range of motion. So it could be a combination, shortwave with another way of treating the disorder. Now, in the wound healing, it has been shown and reported in many studies that you will influence the metabolism, ATP production, for instance, which is essential in wound regeneration, even if in cases where wounds are long existing and difficult to heal. It will, as I mentioned earlier, speed up fibroblast activity, but not only fibroblasts, also osteoblasts and chondroblasts. So type of cells related to joints and bone. And last but not least, inflammatory processes, all the conditions that we know with itis, bursitis, etc., tendinitis. Pulse shortwave will help to speed up that regeneration process, and in wound healing terms also to influence the inflammatory stage of the wound healing. Now, all these effects may have as a secondary effect a decrease in nocisensory output. In other words, analgesia. Hans also mentioned that one of the effects of shortwave diathermy can be pain relief, but actually it's a sort of indirect effect, because with the shortwave device you cannot actually stimulate or depolarize the nerves like you do with tense current. The wavelength is far too long, 11 meters, and afferent nerves will not respond to that. Now, if we have been talking about the effects, non-thermal, and thermal. And after looking at what we know from evidence, we can draw up a sort of list with indications. And if we summarize that, and if we relate it to our field of expertise, physiotherapy, we will see wound healing is absolutely an important and essential one. We can speed up wound healing processes. The tissue extensibility, which I gave an example with the frozen shoulder, but you can relate it to muscle tissue like a calf muscle to increase local blood flow. It will increase the extensibility. Sports injury or trauma, you can reduce hematome or edema, swelling. Actually, pulse shortwave, so pulsed, not continuous, is probably one of the few, maybe the only one, that could be used in a very early stage of rehabilitation. For instance, after an ankle sprain, the first stage will be bleeding for perhaps 30 minutes. There will be some bleeding. The next stage will be the stage where pulse shortwave, non-thermal, could already be used to stimulate that particular phase. Now, pulse shortwave in such a case means non-thermal, a low frequency, low number of pulses with a short duration for each pulse in microseconds, which gives a very low average output. And average output is something that's also confirmed by Tim Watson that's becoming more important. Perhaps I will mention that more towards the end. But in terms of dosage, it becomes important to focus also on average energy rather than the main output, main power of a device. But to come back to the indications, hematome, edema, pulse shortwave, non-thermal for very acute conditions. Inflammatory processes, bursitis, tendinitis, synovitis, etc. You can reduce the inflammation. A consequence of the tissue extensibility, reduced inflammation or swelling will help you also to relieve joint stiffness and as a result relieve pain. So one often leads to the other. So these are the evidence-based indications that we have found. And keep in mind that when using the inductive, you can generate these effects or treat indications associated with certain effects that are more deeply located. Now, the effects, to summarize, shortwave diathermy, the thermal effects are directly the result of heat, deep heat, the blood flow, metabolism, etc. Often they are used more for what is called chronic or subchronic conditions. There heat is allowed, a certain amount of heat is allowed, but non-thermal effect, where there are hardly any or very little heat exposure, is used more for the acute conditions. Acute conditions means conditions recently happened with perhaps a lot of pain, swelling, that involve hematoma, swelling, perhaps some wound healing, where tissue regeneration is essential and reduced inflammation. Now, where there are indications, there are contraindications, of course. The list that you see on the, actually the whole list, you will have to understand, of course, it's electromagnetic energy. So the first few, metal implants, anything that's metal, that could also be in clothing, or rings or body piercings, all the energy will be converted, attracted to those metal parts. So it's very essential before you start shortwave diathermy treatment to carefully ask, or to ask if there are any, for instance, osteosynthesis material, metal implants, or if they're wearing any metal jewelry that is not seen, a necklace, for instance, hidden behind your collar. Also, pacemakers, it's advised to keep a distance of at least 3 meters. Areas that are poor in blood supply. Yeah, there's quite a list. The next one is important as well: perspiration and moist dressings. Shortwave diathermy, Hans has shown that in one of the first slides, that compared to ultrasound, shortwave was more in the tissue that is rich in fluid, like blood and muscle tissue, but also perspiration, sweat. And theoretically, the electrodes could be used with your clothing on, unless with TENS, where the electrode has to be on the skin. With shortwave diathermy, there can be something in between. Could be a towel, for instance, and a towel is advised, by the way. But if you won't use that, and you would just put the applicator to clothing, and if it's some textile, and if you're using thermal shortwave, it could accumulate heat that results in some perspiration, sweat, which is a water content, and all the energy will concentrate on there. So that's also a precaution you have to keep in mind. The same with moist dressing. A lot of shortwave energy will be focusing there on that particular point. Now, since shortwave will also speed up the blood flow, there is some tendency to keep it in mind for hemorrhage, including menstruation. Then one of the general contraindications, pregnancy, especially on the abdominal and lumbar region. Certain implants, it's a relative contraindication. Of course, you can treat an ankle joint, the same with stent. There are indications like fever, contraindications, I mean radiation therapy, and of course sensory loss, because you have to rely on the feedback from your patients if they feel heat, no heat, a little heat, or whatsoever. So you have to rely on the feedback. So if there's sensory loss, then that's a contraindication. Now the next three, those are obvious and contraindications in general. I've mentioned a few times that there's a lot of evidence out there, and that we in 2018 have been searching for evidence ourselves, looking at the best evidence. And I've also mentioned that in the recent years, there's more evidence out there. The level of evidence is becoming better and better. And this is just one slide where you can see a number of publications with the years. And unlike, let's say 10 years ago, you could find a lot of information on shortwave, but most of the information were dated like in the 90s or 80s of the last century. But now there's a lot of information out there. And as I've mentioned, if you're interested to read more, you could either contact us. We also have a number of files, even PDF, that we have been using that could help you to understand, or perhaps better understand, the pulsed shortwave diathermy and the benefits that could bring your patients. We've come, at least I've come to one of the last slides, I guess, of my part of the presentation. And as we have started, it's a presentation or a webinar, I must say, that was organized to support the use of a device, the Curapil 670. It's the latest device for shortwave diathermy, where the latest knowledge and also technology has been incorporated. For instance, what you see on the right-hand side is one of the ways how you can work with a machine, that instead of determining frequency and pulse duration and output energy, that you simply use a sort of slider and use the average output to guide you towards an effective treatment and relate it to the stage of that condition, if it's more acute. Now, acute, the blue, is like your running tap. Blue is cold and red is hot. In this case, you don't want any heat. So you can just slide this point towards that area, and the machine automatically will generate that output, average output. And in the same way, you can tune the amount of energy as needed for that particular disorder. If it's acute with no heat, non-thermal, or on the other side, if it's more chronic where heat is allowed, thermal. And it's just a short thing that I would like to manage at the end of my part of this presentation. And I'm sure that Hans will add in some words as well. So this was my part of the webinar. I hope it was helpful, interesting for you. And if there are any questions, please feel free to ask.
Thanks very much, Ruud. That was very profound. And I think it shows a little bit how shortwave works, what we can do in physiology-wise, but also therapeutical-wise. I think the difference between thermal and non-thermal are also shown very clearly. So you can always choose for more the wound healing, or go in deep and go to muscle healing. I would like to emphasize once more that all the science that was around this on a physiological scope and also on a validity or a clinical relevant scope is all implemented in the machine. So everything works with touchscreen. Everything is based on evidence-based medicine. So in that sense, it makes it for you very easy to use. I think this is the end of this webinar, and we asked you to wait and hold your questions. So I'm going to stop share the screen so that we can communicate together and see if people have questions. So Ronan, would you like to guide that?
First of all, I want to say thank you for a very comprehensive lecture about shortwaves. It was very profound and interesting from many different ways. I have two things that I think would help for the physiotherapists. One of them is maybe you can give some tips about where to locate the electrodes. And the other one, maybe it's not even necessary because you showed this scale, but how do you, what I mean is, what are the tips for the best treatment effect?
Okay. Let me start and then Ruud will finish. This is mostly the work, how we do it. I'm a little bit more superficial. He's a little bit more profound. I would say if you check the protocols, then you immediately see the adjustments in combination with the indications, which means that if it's for a muscle, if it's for bone, if it's for wound healing, you'll immediately see how the protocols with the scientific background are related to the adjustments. Also, when you see the machine, like Ruud already emphasized, when you start with the cold, it's always for acute injury, because we do not want to put any heat in a physiological inflammation. So in that sense, you can work with the acute, subacute, subchronic and chronic tissues. This is for every physical therapist easy to determine whether they are in what stage. And then if you are unsure about, hey, how much should I adjust for this particular indication, then from my point of view, I would see, hey, what protocols, what data do we have, what scientific input do we have, and what's correlating with the injury that I'm now facing. So with all itises, no heat, so you will always go to at least acute or subacute and not to subchronic or chronic, okay?
Yeah.
Okay.
Can I add in something from a practical point of view? Hans already mentioned that the protocols give you information on the positioning. There's another aspect that's important to realize with the inductive electrode, the drum, the one and only electrode that you have to use. Actually, you're using the magnetic field, and the field is strongest on the edges of the electrode. So it's not the center. You would expect the center, so you would position the center of the coil to, for instance, epicondylitis on the tendon. But the edge of the electrode is where the field is strongest. Now, there's another thing. The Curapulse works with contact. So there must be, so the circuit must be in contact with the patient, right? Or the towel in between. So it has a sort of contact control mechanism like ultrasound. So if you lose the contact, the energy transfer will be stopped. So that also ensures you an effective treatment. So there must be a good contact. If the contact is sufficient, then there will be a sort of signal and also visual signal that the energy is actually transferred. So keep in mind the edge of the coil, there the field is strongest. And we do have a sort of therapy book of the Curapulse, and there are some pictures shown for various indications with the positioning of the circuit plate. And sometimes people say, hey, that's strange. The position is a little bit aside to where I expect the problem or where I know that the location is.
Because of the edges.
Exactly. That's it. Yeah.
Very good. Thank you. It's very good stuff.
You're welcome.
Okay, are there any other questions?
No, I think for this point in time, thank you very much. And thank you, Vlada, for joining us and, you know, being the Maccabi's representation here. And again, Ruud and Hans, thank you very much for a very, very knowledgeable presentation.
Most
and
welcome.
hopefully, you know, this also is implemented, you know, in the clinics.
We hope so too.
Yeah, would be nice. Thank you.
Okay, thank you very much.
I will send the presentation. I will send the,
Okay.
Thank you very much. We will send the presentations to Micha so that you can later on at least see the scientific reviews, etc., etc. Okay.
Great. Thank you very much.
Right.
Bye bye.
Okay. Thank you.
Bye bye.
Bye. Bye bye.
Okay.